Good afternoon, everyone. Welcome to CMC Medicine PG online sessions. This is our second session in terms of having lectures online. It's a series of lectures. This will be from the Department of Infectious Diseases. We'll start off with Dr. Abi Manesh. He's Associate Professor in the Department of Infectious Diseases. He'll be covering the topic treatment of serious drug-resistant bacterial infection. So you will be hearing from him for the next 1 hour, but we'll request him for another 2 minutes to stay back for any further questions from the attendees. If you can either vocalize your doubts, otherwise you can put up your doubts in the chat box. These lectures will also be later on uploaded in the YouTube medicine website. So all the best, guys. Let's now moving on to Dr. Abi Manesh.
Thanks, Anju. So the essence of this presentation is kept at a level of postgraduate trainee in medicine, so that this basically will cover a host of drug-resistant infections. Very briefly, what one needs to do if they are encountering such an infection at bedside. So there will be very little. Sorry. Yeah, there'll be very little information on a lot of theoretical basis, but we will just focus on how to manage these people preferentially. Now, this is a quick details of a 50-year-old lady, one of the sorts you would see very commonly, be it in your emergency or in the ward. So a diabetic who presents with frank features suggestive of a pyelonephritis. She receives treatment with cefotaxime. She has leukocytosis, she has borderline blood pressures, and has a pyelonephritis. And by one look at her, you know that she is very likely bacteremic as well. So I'm going to show you the urine and blood culture report of this lady, and you would realize that this lady has an infection both in blood and urine by E. coli, which is exhibiting extended spectrum beta-lactamase production. Just few quick things. How do you know it's extended spectrum beta-lactamase production? This is basically a beta-lactamase which has expanded its spectrum of cover to knock off more antibiotics. So any beta-lactam antibiotic, be it penicillin or cephalosporin or monobactams like Aztreonam, can come under the influence of ESBLs and get deactivated. Now, what are all the clues in the antibiogram to say that you're probably dealing with ESBL? You look at cefotaxime, ceftazidime, ceftriaxone, cefpodoxime. All these, if they are showing resistance, then you have a high suspicion that you're probably dealing with the ESBL isolate. If you look at this patient, there is cefpodoxime resistant, which is a sensitive surrogate marker for ESBL production. Now, the question is, let's just quickly jump to how would you treat her. Now, the singular question here is, should we use a carbapenem or a BLBLI? This question was answered in the Marino trial. So this is a large trial which took place in about 9 countries, 26 hospitals, a pragmatic design where they took patients who had a ceftriaxone resistant Enterobacteriaceae bacteremia, presuming these were ESBLs, and they did a susceptibility for piperacillin tazobactam. By inclusion definition, all of them were susceptible to piperacillin tazobactam. One thing to note is they are looking for a definitive therapy and not as an empiric therapy. So once your cultures grew, they did susceptibilities, and 3-4 days down the line, or when they are trying to tweak therapy here. Now, the primary outcome in this trial was a 30-day mortality. Very disappointingly, this trial showed that piperacillin tazobactam produced increased mortality. This was a non-inferiority design, and the non-inferiority margin was 5%. But the risk difference was quite high. Now, then people started wondering why this difference was there. On re-examination, people realized that some of the piperacillin tazobactam susceptibilities that were calculated in the trial were wrong. When they recalculated, the mortality difference actually fell. If your piperacillin tazobactam MIC was less than 16. The difference was 5%. That's exactly on the non-inferiority mark, and 4% if your MICs are less than 8%. Something interesting in the genomic data from the Marino trial, if you look at the way the susceptibilities were determined, you see the green ones, those are the ESBLs. If you look at the gray ones, no, those are the narrow spectrum OXAs, OXA 1 typically. When narrow spectrum OXA comes together with ESBL, you have a disproportionate increase in MICs. That's what we presume sort of turn the tide against piperacillin tazobactam and responsible for some of the poor outcomes. So at the end of the story, can we just leave piperacillin tazobactam for ESBL, or should we use it? My personal take is that if you look at the Marino data, if you have a patient with urinary source, not in shock, stable looking, few comorbidities, not immunocompromised, please go ahead and use piperacillin tazobactam. And remember to check pip test susceptibility by a reasonable method like MBD when microbroth dilution when you are using piperacillin tazobactam. Not that you cannot use upfront as well. Go ahead and use it if your patient is stable and watch over them closely. Now, the second question is, the common one asked is, how long should we treat a GNB bacteremia? So this is a randomized controlled trial that got published in 2019 from Michael Paul's group. So it showed that regardless what is the source of bacteremia, be it UTI, non-UTI, whether the empiric antibiotic covered it or subsequently modified, whether there is MDR or non-MDR, watch out, their definition for MDR is actually any resistance, including ESBLs. ESBLs are the MDRs they are talking about. So it's not the carbapenem resistance or anything like that. They mean ESBLs. All that patients can be safely discontinued therapy at 7 days. Now, when you try to decrease duration to 7 days, carefully look for, have I sorted out the source completely? So if there is an abdominal source for your infection, at least ensure that they have received 3 to 4 days of therapy after the abdominal source is controlled. Let's say there is a urinary tract infection, it's an obstructed urinary tract, ensure you have relieved the obstruction, or let's say it's a line, pull out the line and ensure that is done before we cut short therapies and all that. Now, this is an interesting data, albeit retrospective data, but a large data set, around 2,500 patients from Tama. So what they looked at was at day 2, they assessed, is this patient well enough to take oral antibiotics in patients with gram-negative bacteremia. So if they were well enough to take oral antibiotics, they switched them to oral antibiotics by day 2 to 5 and looked at whether the mortality is any different between the oral step-down therapy group and the IV treatment group. So they showed that there is no difference in 30-day mortality. Now, the very important question one needs to answer is that, do you have an effective oral therapy? So what are all the good oral therapies, especially for Our Lady, like her with a urinary source? We would be very excited to have susceptibility to Saptran or fluoroquinolones. So those are some things we would look out for when you actually try to shift patients to oral therapy. So encourage oral switches early whenever it is possible. Now, what about non-carbapenem, non-BLBLI options for ESBL? So I'm talking about aminoglycosides, fluoroquinolone. Let's say it is levoflox susceptible. You get to know the day 2 of infection. What can I do about it? This interesting data is from the increment cohort of ARLG group. So they looked at the other active agents. You can see that N of 86, that's predominantly fluoroquinolones and aminoglycosides. If you look at their outcome doesn't change. So feel free to use other sparing agents like aminoglycosides, fluoroquinolones, and step down to oral whenever possible. provided your patient is well and stable. So that's the message from the E. coli. Now, do you need repeat blood cultures in GNB bacteremia? So somebody, let's say this lady, would you like to repeat a culture? This question was addressed in a retrospective data of 377 patients, which essentially showed that follow-up blood cultures have a very poor yield, especially for gram-negative bacteremia. So you need to have 17 follow-up blood cultures done to get one positive, and usually your treatment doesn't change because of that. So would you like to send? Don't send. Not useful for routine care if your patients are on susceptible antibiotics. Now, what are all the exceptions for sending repeat blood cultures? If there are persistent fevers, immunocompromised patients, and there is clinical evidence of metastatic infections, sounds reasonable to check for repeat cultures when you have a Enterobacteriaceae bacteremia. So with this, I think we sort of wind up the ESBLs and their management. We discussed about how long to treat, what to treat with, when to use piptazo, and when can you use fluoroquinolones, aminoglycosides, how to step down to oral, and should we send a repeat culture. Now, the second section we will talk about is AmpC carrying organisms. So these organisms, especially what you would come across in clinical practice, is Citrobacter and Enterobacter. If you take Enterobacter, it is the third commonest gram-negative isolate among the Enterobacteriaceae in a hospital. So you should be aware of that. What Enterobacter has is a chromosomal AmpC. So these sort of, when they are exposed to beta lactams, these are overexpressed and they can quickly knock off the antibiotic, and they are not the most of the beta lactamase inhibitors don't cover AmpCs. So that's the problem. So one of the things has been that if you use a BLBLIs for these organisms, you might land up in therapy failure. If you look at various data, the therapy failure ranges between somewhere between 10 to 15%, depending upon the study you talk about. Now, this is a recent meta-analysis from OFID in 2019. So when you look at a forest plot like that, you want to play safely, isn't it? The results are all over the curve in this forest plot. So I would suggest that when you have a serious infection with AmpC producing organism like Enterobacter, maybe we should stick to carbapenem and probably should not go for a BLBLI. That's one snippet with AmpC. They will switch gears to go to carbapenemase producing Enterobacteriaceae. This is the bane of recent times, isn't it? We have so many organisms resistant to bugs. These are periplasmic space. I hope you can see my cursor below the outer membrane. These enzymes exist and knock off antibiotics as they come in. The most notorious of the sort is Klebsiella, and bacteremias, depending upon where you look for, the mortality ranges somewhere between 20 to 60%. If you look at the panorama cohort, including Indian data, it ranges about 30%. So very high mortality. Now, one of the basic things you need to understand, I'm sure all of you know, I'm just giving you a recap, is that you're familiar with the various enzymes that produce the various carbapenemase enzymes. So in your mind, you briefly classify them into NDM, New Delhi metalloproteinases and likes, OXA48 and likes, and KPCs. For practical purposes, we can forget about KPCs because they are not that common in Indian setting. What India has is OXA48 dominant. Sometimes you might have NDM along with it or isolated NDM. So the treatment regimens for these are slightly different. So we need to remember these two for practical purposes as different carbapenemases you need to remember in the Indian situation. As I told you, the epidemiology of these infections are quite different across the globe. So the blue color, the violet-like color you see for India is actually NDM plus OXA. And if you come here the maroon, deep maroon like color, what you have is oxa there, and this one is predominantly KPC. So the US, UK, other European countries, so you have more of KPC is what. So depending upon that, your treatment regimens might vary a little bit. Now, when you encounter a CRE infection, what to do? You do 5 steps. Request a Carba expert first. You want to know whether it is an NDM, OXA, or KPC. Ask for a colistin susceptibility. It takes 1 to 2 days. It's done by microbroth dilution. So ask at the get-go. And ask for colistin MIC that would give you, and meropenem MIC to see whether there is a small benefit of combining meropenem to colistin in these patients. Start promptly on active antibiotics. What are all the active antibiotics? We will come to it shortly. At the get-go, explore susceptibilities for alternatives. Aminoglycosides, TG-cycline, fosfomycin, Septran, chloramphenicol. Depending upon the infection you're going to talk about, these all can come handy. For example, if you want to say some urinary tract infection, aminoglycoside is susceptible, you can step down to that. If there is an abdominal infection, TG-cycline will penetrate beautifully. Fosfomycin, ideal for an urinary source. TMP-SMX, again, bone, urine would be excellent penetration. Chloramphenicol, you have occasional rare patient with gram-negative infection in the brain. Chloramphenicol susceptibility, it's going to penetrate very well. So you optimize therapy based on the site of infection. For example, polymyxin is not going to get into the kidneys, polymyxin B, so don't use it. Toxicity, patient status, how sick they are, etc. For example, in somebody who is septic, you're not going to go for a aminoglycoside monotherapy. Now, what are all the effective options? So if you have an OXA48 or another OXA or KPC, you could use colistin, ceftazidime-avibactam, and or other alternative agents wherever applicable. NDM and the likes use colistin, ceftazidime-avibactam plus aztreonam. So that's something we need to note. If you use ceftazidime-avibactam for an NDM, you should use aztreonam along with it for effect totally together. It brings down the MICs a lot, and aztreonam independently can get inactivated by an ESBL. So you have ceftazidime-avibactam on board. So together you have a good outcome. Other alternative, depending upon the source of the infection, you could use, or as we discussed, aminoglycoside, TG, phospho, TMP-SMX, and chloramphenicol. Now, can I use polymyxin B and colistin interchangeably? Generally, polymyxin B is preferred over colistin. The reason, it's not based on any actual clinical comparison data. It's more to do with how the drug behaves inside the body. If you look at colistin, it's a prodrug. It takes some time to achieve steady state concentrations, even if you give a loading dose in critically ill people. On the other hand, polymyxin is an active drug, and polymyxin is maybe less nephrotoxic. So use preferentially polymyxin B, and not useful in renal infections, polymyxin B, but maybe better penetration in other areas. Now, this is the interesting data. I just want you to highlight what I have shaded here. This is the colistin dosing compared with creatinine clearance. To the right, what you're seeing is actually the blood levels of colistin measured. So what you would realize, when the creatinine clearance is more than 80, almost all patients received a colistin base activity of around 300, which is equivalent to the colistin doses we are using, somewhere high. Very good doses were used. Still, if you look at the levels of colistin that is achieved, you definitely want a level of more than 2 in serious infection. You realize that it is well below 2. So the logic of it is that even if you try hard, in somebody with a renal, normal renal function, it's going to be really difficult to achieve a good colistin concentration easily. Now, one of the questions is that, can I do colistin levels and titrate for outcome? So far, no, there is no routine role for colistin levels. Levels, usually what people report is steady state, corresponds to toxicity, doesn't correlate with efficacy. What we are interested, it's a concentration dependent drug, isn't it? So you want AUC by MIC calculated, and against that the efficacy has to be measured. That sort of data we don't have, but whatever we have so far doesn't seem like it helps so much to measure colistin levels. Now, there are problems with colistin. You realize that colistin is a very, very strongly positively charged antibiotic, and the outer membrane of the gram-negative bacteria is negatively charged because of the lipopolysaccharide. Now, you can imagine it like colistin, like a spacecraft landing on the cell membrane of the bacteria. The attraction is because of the charges. So positively charged colistin, negatively charged membrane, and it comes and attaches and pokes holes in the cell outer membrane. Now, the way organisms manipulate it is that they change the negative polarity at the LPS subtly. So they make it less negative, so that interaction with the positively charged colistin doesn't happen. Also, if you thicken the capsule, then the exposure of LPS for interaction with colistin decreases. What I've shown in this complicated figure is the host of gene systems that are involved in maintaining the negative polarity of LPS. So you could have mutations anywhere along those lines to have a less negativity, less interaction, and poor colistin efficacy. So when somebody gets exposed to colistin, invariably down the line, the negativity in the LPS is modulated by the organism. Now, there is small series of emerging data. You would realize the numbers are so small, showing that colistin doesn't perform as well compared to other alternative agents. Many of them are done by pharma companies, and they don't look at only bloodstream infections. They look for a host of infections. So there's some concern about colistin susceptibility. That's why when you look at the colistin reporting from our microbiology lab as well, you would see only intermediate and not sensitive. So this needs to be studied more to say that whether we should go for alternative agent if present upfront in these infections. So that brings us to a closure for carbapenem resistance in Enterobacteriaceae. So remember, ceftaz-AV with or without aztreonam and colistin are the treatment options. And we discussed the whatever other antibiotics you can use and the problems with colistin. Those are the things we have covered. Now we are coming to carbapenem-resistant Acinetobacter. This is a sad reality in Indian scenario. If you go to our ICU, more than 70–80% of our VABs, Acinetobacter is carbapenem resistant. Ceftaz-AV is ineffective against Acinetobacter. So the only workhorse antibiotic we have is currently polymyxins. Polymyxins with or without tigecycline, aminoglycosides are the only current option. Colistin resistance, fortunately, is a rare phenomenon in crabs. When you compare it with Klebsiella, if you look at our institution data now, it's about 40–50% of our Klebsiellas are actually colistin resistance. Now, no role for combination therapy in crab. This is answered in the IDA trial, which had 77% of Acinetobacter infections. This trial recruited serious gram-negative infections, mixture of bacteremias, VAP, HAP, and urinary infections. No difference in the composite of mortality and how patients improved. So no role for routine combination therapy with meropenams. Only colistin should be used. Only concern is that the levels achieved by colistin in the lung fluid is quite low. The commonest thing with carbapenem-resistant Acinetobacter one would see are lung infections. Unfortunately, the colistin levels can be low. Some people believe in augmenting colistin by giving inhaled. That's one of the options too. Now, quickly on MRSA. So we have finished gram negatives. We did ESBLs, AmpCs, CRE, CRAB, and then the final bit we are going to do MRSA. So MRSA, the treatment is as for any bacteremia, source control plus appropriate antibiotics. What is appropriate antibiotics for MRSA? You can use vancomycin or daptomycin. Now, teicoplanin is an alternative with less nephrotoxicity. It's not widely used for lack of data. There's no head-to-head comparison with teicoplanin, but looks like in a small meta-analysis, it performed as well as vancomycin. One of the things is to ask for vanco-MICs always. And this is one important thing. I'm sure all of you do this. Send a follow-up blood culture. At 48 hours, it's going to predict, if it's positive, it's going to predict mortality, metastatic infections, and identify those patients who need prolonged therapy. For MRSA infection, there is no role of cutting down therapy, decreasing the duration. You would give minimum 2 weeks. If it's complicated by follow-up blood cultures, positivity, metastatic infections, you're looking at 4 to 6 weeks of therapy. Vancomycin levels after 5 doses, you could do a AUC by MIC. Targeting more than 400 is something you could do when you're dealing with a serious infection like a bacteremia. Now, there are 3 caveats you should remember when you use vancomycin. One is you should always ask for an MIC, because as I've shown in this meta-analysis, if you have an MIC more than 1.5, your risk of treatment failure is quite high. And switch to daptomycin in that situation early for a better outcome. Remember, daptomycin susceptibility is actually influenced by vancomycin exposure. So when you use daptomycin in these situations, you should use something like a 10 milligram per kilogram dose of daptomycin when you use in these situations. Now, there is a problem of heteroresistance. What is heteroresistance? There is a group of colonies. Some among the colonies have lesser susceptibilities and higher MICs, and this is not genetically mediated. So you have these people mixed among the colonies who are less susceptible. Typically in a plate, they may have smaller colonies in a culture plate. They can also produce poor outcome. When to suspect the issue of heteroresistant, previous vancomycin use, high bacterial load infections like endocarditis, persistent bacteremia, you're not achieving vancomycin levels, and presence of indwelling devices. If you suspect your patients could be having heteroresistance, we have a fantastic lab, of course. They will help you out looking for heteroresistance and see whether your particular isolate shows heteroresistance. Now, the third caveat while using vancomycin is poor tissue penetration. Remember, vancomycin is a large molecule. It's a clunky molecule. It's not going to get into tissues very well, especially into the lung, skin and subcute. So you could consider alternatives in that situation. So for example, for brain, you go for linezolid. For lung, you could consider linezolid more. And for skin and soft tissue, you could consider clindamycin. You can consider linezolid. You can consider fluoroquinolone if it is susceptible. So all those options can be used. So these could be other options that can be used in MRSA treatment. So summary, vancomycin remains the first line agent. Daptomycin probably in high inoculum bacteremias, right-sided IE, those such situations you could consider dapto. Linezolid in pneumonia, brain, complicated SSTA, you could go for linezolid. Teicoplanin, almost comparable efficacy, probably with little less toxicity. The last 2-3 slides, we are going to look at community-acquired meningitis because it's a serious infection with the concern of drug resistance. So let's do this. So this is the data from a study from CMC. Dr. Balaji was a lead investigator, which got published in 2018. These are the commonest causes of meningitis in our population. So if you look at it, H flu, strep pneumo, Neisseria, occasionally in some centers is how community-acquired meningitis is distributed. Now, if you look at the pneumococcal susceptibility in detail, you would realize that 13.8% of pneumococci are resistant to penicillin. and half of them are resistant to cefatoxime as well. So that's a risk you would not like to take in a very serious infection like meningitis. So the optimal antibiotic therapy for community-acquired meningitis in India should be ceftriaxone, which would cover your Neisseria, H. flu, and penicillin-sensitive pneumococcus, and also vancomycin. Just put where to add steroids as well there for completion's sake. So take-home message, we discussed about ESBL producing Enterobacteriaceae infections. If someone comes sick, go for carbapenem. If they are not sick, consider BLBLIs like piperacillin tazobactam. Consider step down to fluoroquinolones, aminoglycosides, TMP SMX, oral therapy also if your patient is doing well. AmpCs, preferably stick with carbapenems. CRE, you have options of colistin, ceftaz-AV, and look for the carba expert, decide the mutation, and then go accordingly. We looked at Carbapenem-resistant Acinetobacter baumannii. So very unfortunately, very little therapeutic options. So colistin is probably the mainstay and no role for combination therapy. MRSA management, the workhorse is going to be vancomycin. I told you where to use daptomycin when you're stuck with MICs more than 1.5. There's a concern of heteroresistance. You could use daptomycin, and linezolid, preferably in pneumonia and brain. You could use linezolid and other agents appropriately, skin and soft tissue, etc. An empirical choice for community-acquired meningitis in Indian setting, one would like to have vancomycin on board because of the chance of penicillin resistance pneumococci. If there are questions, I would like to take. Okay, thanks. So let's go one by one. I'm sure you all can see the questions there. So one of the questions is that what are all the options for Acinetobacter baumannii when colistin MIC is intermediate? We discussed this in the sense that you won't have a sensitive colistin MIC because of some concerns of poor outcome. So all our colistin MIC is going to be intermediate. But if you have a patient who is worsening despite colistin use, one of the options is to go for tazobactam. Tazobactam has intrinsic anti-Acinetobacter activity. So you could go for high-dose tazobactam as an option in this people. The second question is what is the, there are other alternative combinations like rifampicin and all people have tried, been evaluated even in RCTs without benefit. So Acinetobacter baumannii, as Tina rightly pointed out, she's saying that because there's very limited options to treat Acinetobacter baumannii. So unfortunately, there are not many options, and it's not a bug that sort of works with combination well. So combination therapy strategies have repeatedly failed for Acinetobacter. Now, the other concern is what is the clinical relevance of inoculum effect? Does it affect the choice of piptazo? Choice of piptase in ESBL bacteremia. Okay, let's just go through it. So inoculum effect, if you're not familiar with the term, basically, let's say you have a host of bacteria, and bacteria has a lot of beta-lactamases, and the role of tazobactam in piptazo is to knock off the ESBLs. So when the antibiotics start lysing the bacteria, more ESBL suddenly gets released into the bloodstream. So they can sort of overwhelm the capacity of tazobactam to lyse, and you can land in therapy failure. So this has been shown to be a concern in animal models. Very difficult to study in humans, but if you have to translate inoculum effect to humans, you should probably think of a septic patient who has a very large load of bacteria, who is in shock, like the lady I showed you. So in those people, preferably it's better to avoid BLBLIs. That's why I had also mentioned that, is your patient stable? So when would you use piperacillin tazobactam? somebody who is not in shock, clinically stable, urinary source, few comorbidities, non-immunosuppressed, and even if you start piptazo, get piptazo susceptibility concretely. Yeah, so the third question is a mirror of what Tina raised. It's a very important concern. We don't have other antibiotics, unfortunately. One of the things is to explore amikacin. Sometimes amikacin can retain susceptibility. TG can also be used for Acinetobacter. You could look for TG cycline. So predominantly, these are not standalone agents. So these are all partner agents with colistin. So we don't, usually people would not like to use TG alone or for that matter, Tazobactam alone. These are all in partnership with colistin usually. Aishwarya had asked, regarding piptas for stable UTA, does the dose of piptas instead of any correlation with, oh, okay. So okay, there are two things in it. She had raised concerns about the dose of piperacillin tazobactam that is used and also correlation with recurrence of UTI. Now, the first question, the dose of piperacillin tazobactam it is used, if you look at the Merino trial genomic data I showed, the MIC of piperacillin tazobactam is quite wide, often sometimes crossing 8, ranging to 16 and plus as well. So in that situation, if you want to get the best benefit, you actually want to use Q6 thali of piperacillin tazobactam. That is going to be the best use of piperacillin tazobactam. Now, recurrence of UTI, I wonder whether there is some data. I mean, if someone is aware of something, please update. You can put it in the group also, but I'm not sure whether this has been correlated with recurrence. I know people have looked at bacterial clearance in the urine as an endpoint, but I'm not aware of data that has looked at long-term to look at recurrence. But one thing to finish our discussion in recurrence is that recurrence is often due to anatomical and functional problems than failure of an antibiotic. So you have either a stasis because of diabetic cystopathy or an uncontrolled diabetes or some stone sitting there. Things like that are the ones which are associated with recurrence very strongly. Those are the things that need to be addressed to avoid recurrence. Amita had asked if BLBLIs can be used for, yeah, does it include augmentin? Is it okay for cystitis? This is assuming, yeah, that's a very interesting question. Only thing is this augmentin, our oral absorption rates are not that high. And augmentin is not an antibiotic that particularly concentrates in the urinary tract. Those are the two problems when you want to use augmentin as a step down. So BLBLIs, oral BLBLIs typically have this problem. They are not the best ones to step down orally to. That's why when we discussed, I specifically sort of mentioned that you focus on other things that would get you the urinary penetration you want, like TMP SMX, or you could use fluoroquinolones if they are susceptible. And even if you think of aminoglycosides, once a day aminoglycosides, that's going to be easier therapy to step down and discharge somebody. So preferably we should stay away from augmentin because of absorption issues and lack of penetration in the urinary tract when we try to step it down.
One more question.
Yeah, role of nitrofurantoin in patients who grow. I understand. Yeah, okay. So nitrofurantoin is an excellent antibiotic if you're thinking of lower urinary tract infection. Please go ahead and use it. Regardless, even if it is a CRE, go ahead and use nitrofurantoin. The individual susceptibility of drugs will be still maintained. They may lose susceptibility subsequently, but at that get-go, you will have a treatment effect. Please go ahead and use it. You have very clearly mentioned that it's only a cystitis without any systemic symptoms. Very clear question. So in that situation, please go ahead and use it. Yes.
Dr. Abi Manesh, any further questions?
I realized only the faculty has asked questions.
Yeah, can't see any PGs asking questions yet. Any queries?
Yeah, anyway, it's an ongoing discussion. We can just catch up in other modes as well. If there are concerns, please feel free to raise your concerns. Yeah. Thank you so much. It's a pleasure.
Thanks a lot, Dr. Abi Manesh. That was a very informative and lecture. I think it was very practically oriented. Hope you guys have questions and doubts in the future. Once maybe you missed out on the lecture, maybe you'll be able to access this lecture in the website, medicine website, YouTube. So if any further queries, like how Dr. Abi Manesh told, you can approach him. He's a very approachable and practically oriented doctor, so he can come with the queries. Thanks a lot, guys, for the lecture. We'll wind up now.